So this is a preclinical study on a glioblastoma cell in the mouse. SDUR means standard high carbohydrate diet. Let the mouse eat as much as he wants. Eat as much as you want. Very high carb diet. The standard diet restricted. Just restrict the diet to reduce 40% of the calories. And you get therapeutic ketosis from that. And we got a 60 to 85% reduction in the size of the tumor. You can see the guy on the right, his head is less swollen than the guy on the left, just by restricting the calories. What went on here? Then these little black squares, each mouse is a square is a mouse under a different dietary condition, right? So and you look down on the bottom, this is a linear regression analysis, and if you look down on the bottom, as glucose goes down, beta-hydroxybutyrate, BOHB is a ketone body. That's what happens. When you stop eating, the brain needs energy. We start mobilizing the fat out of our body stores, and they get converted into beta-hydroxybutyrate, a ketone body, and replaces glucose for our brains. Evolutionarily conserved adaptation. Human beings evolved to starve. If it weren't for our ability to live long periods of time without food, none of us in this room, myself included, would exist today. The mice can't do what we can do. Mouse will die in 5 days from starvation. Humans can go very, very long before they die from starvation, depending on how much body fat you have. Now on the right, you see tumor weight and the glucose. So as glucose levels go down, the size of the tumor goes down. The higher the blood sugar, the faster the tumor in these mice go. The lower the blood sugar, the slower the tumor grows. Very clear. This has now been replicated for humans with brain cancer and colon cancer and breast cancer. If you want your cancer to grow fast, do everything you can to make sure your glucose is as high as you possibly can get it. How do we do that? We eat cake, and we eat ice cream, and we eat Enfamil, and we eat all these different kinds of things that they give to the cancer patients in the clinic. Right? You go down to the oncology, eat whatever you want. Don't you know that there's a large number of papers in the literature that say that your cancer will grow faster if your blood sugar is higher and will grow slower if your blood sugar is lower? No, I never heard of that. These are the data. And I've referenced from a vast amount of human data. It was based on our work in the preclinical study, and then people looked at it in humans and they found the same thing. Also, when you get your blood sugars down and ketones up, it becomes anti-angiogenic, which means the blood vessels go down inside the tumor, the angry blood vessels. The tissue becomes less angry, less inflamed, and becomes pro-apoptotic. You start killing these cancer cells. There's no drug in the pharmaceutical armamentarium that will do what this therapy will do. But it requires personal discipline. It's not easy to do this. It's much easier to sit there and get infused with some toxin, or get your head irradiated or body irradiated. But these are the evidence. It's published. Now I'm going to talk about glioblastoma. This is a terribly aggressive tumor, and we all know it's poor prognosis, no effective therapies, multiple cell types. This is the tumor that just recently killed Senator McCain, before Ted Kennedy and many others. Highly invasive, it spreads outside the... So let's talk about this, because this is one of our major focuses in the lab. You manage this guy, you can manage anything. This is a cross-section through someone's brain who perished from GBM, glioblastoma. You see the big cystic spot. And if you notice, there's a midline in the brain from the top. You see that line, and it gets curved out to the left. That's the pressure from the growing tumor pressuring the ventricles. Most of these poor folks die from intracranial pressure. You can see the big ugly cyst. Now, the problem, you can't cut these guys out because tumor cells use the blood vessels as a kind of a railway system to get through the brain, and they go across the top of the blood vessels at one of their ways of invading. And those little purple cells on the right are cancer cells on the top of blood vessels, and what it is they can just, so you don't see them on these big scans. You only see this necrotic large area when you do a scan. You can't see these tumor cells that are all through your brain, and this is one of the reasons why it becomes very difficult to manage this disease. Now here's mitochondria are abnormal in glioblastoma. So here, normal, you see on the left, the lighter color bars are the normal, and the GBM have much fewer of these normal-looking mitochondria. And then abnormal mitochondria are enriched in the GBM cells. This is exactly what I said before. The cancer cells have damaged mitochondria. What does that mean? It tells us right away, those cells are fermenting. If you can't respire, you must ferment. There's no other way you can get energy if your lungs, if your respiratory system doesn't work. Okay? So the cells ferment. That tells us, that's the clue. The cancer cells are fermenting. And what they ferment glucose and glutamine. So those are the two fuels. And you know what's very interesting? When the tumor cells suck down a lot of glucose and glutamine, they become remarkably resistant to radiation and chemo. Okay? They say, well, the cancer came back. Oh, it was resistant. It was resistant because they're fermenting. What happens if you take away their fermentable fuels? Oh, you can kill them. So this, I'm not going to go through the mechanics. They get energy from fermentation metabolism using two primary fuels, glucose and glutamine. They can't grow without energy, period. They can't use ketone bodies because their mitochondria are defective. Transition the body over to ketone bodies. Your normal cells can use them, but the cancer cells can't. So that means we've marginalized the enemy. We've put them into a box, and now we slowly degrade them by targeting glucose and glutamine. Now, what do we do in the clinic when somebody is diagnosed with a glioblastoma? Okay? As we heard from Pam and we heard others last night, shock. The first thing that happens is total shock, not only to the patient, but to the patient's family and friends. Because immediately they rush to the web and they say, what is this glioblastoma? Oh my God. You look at it and you go, oh Jesus. So before you know what to do, they got you in the operating room, and sometimes that's necessary, sometimes it's not. And they've got you scheduled for radiation, and they've got you scheduled for chemo. And by the time you wake up, you're already, and I'll show you what's going to happen. We did the neurochemistry. We defined the neurochemistry. Now people say you need clinical trials to prove this. The biochemistry tells us what's going to happen. The neurochemistry of the brain, we can make a prediction as to exactly what's going to happen based on what we know, the energy metabolism of normal cells and tumor cells. So here you have this brain, and the tumor is cut out, and when you cut that tumor out, you leave a beautiful hole, a very inflamed hole, and then you irradiate, you break apart the very tightly linked neurons and glial cells. They're all in this beautiful society, very interactive, and now they spew out their glutamine into the microenvironment, and those tumor cells suck it down like there's no tomorrow. You created a Garden of Eden of fuels for these surviving tumor cells that were not first moved out from the surgical resection. Now, when your head is irradiated, your brain tends to swell, and the area tends to swell. So what they do is they give you high-dose dexamethasone, which is up on the top there. Dexamethasone induces hyperglycemia. That means high blood sugar. Now, so we get a massive amount of glutamine being released by the surgery and by the radiation, and we get a higher blood sugar. I don't have the time to tell you, there's a whole bunch of other things that make that environment for the tumor the best growing environment. It's like taking grass and putting flowers and putting every kind of a fertilizer on it. It explodes and grows, and it's vibrant. So we can predict without any degree of certainty that this therapy will lead to the rapid recurrence and the death of the majority of people that receive this therapy. I don't have to say any more. I just said, well, where's the evidence? Right here. Now this Dr. Stoop, defined the standard of care for glioblastoma. Radiation temozolomide, and now he's coming out and saying maybe steroids are no good. But if you look at the red line are those poor souls that were irradiated alone. Right? They're all dead. This is data. These are the data. I could predict this based on knowing the biology of the tumor. You don't need a clinical trial. You just have to understand the biology and neurochemistry of what's going on. You can predict what's going to happen. And then here's the evidence to prove that you knew what you were talking about. These guys are all dead. Not a single survivor in this study. Predictable. They're dying from the radiation treatment. I'll tell you more about that. Now, the little blue line was the biggest breakthrough in glioblastoma in 75 years. What did they do? Temozolomide. It's a toxic alkylating agent that increases driver mutations, which is even more absurd. Okay, temozolomide, nausea, vomiting, fatigue, and diarrhea. Indirect forms of calorie restriction. No one's done a controlled experiment to test what I just told you. Who's going to do that? Here's an example of, let's put faces on the tragedy. Brittany, diagnosed low-grade tumor in January 2014. Low grade. Doctor's very optimistic. Oh, you have a low-grade tumor. 3 weeks, boom, glioblastoma. This is what I'm talking about. You touch the beast will bite you if you don't know what you're doing. We have what they call secondary glioblastoma. These are people who go on and get glioblastoma from trying to cut out a low-grade tumor. You create the environment, this tumor morphs into the big daddy. So then she goes on standard of care, and you can see her on the right. She's got the moon face. She doesn't look anything like the one on the left. That's from overdosing steroids. High-dose steroids cause moon face, thin skin. So she looks at the data, and she says, I'm out of here. I'm going to die. I'm going to Oregon. She's from Northern California. She goes across the border, and she dies with dignity with her family and her new husband. And she writes it all up in People magazine, so you can go back and read People magazine and get the full... Nobody's talking about what put her in that state in the first place. It was, is it moral to take your own life when you have a terminal disease? That was the big subject of the story, not the fact that radiating the brain put her in that position in the first place. Here's Pablo Kelly. He had a diagnosed GBM in 2014. He's an English guy from Devon, England. He emailed me and he said, you know, they told me I have a GBM. They want to immediately do surgery, radiation, and chemo, and I don't want to do it. So I said to him, well, you might want to try to get yourself into therapeutic ketosis. So he says, okay, goes into therapeutic ketosis. I hadn't heard from him for 2 years. Didn't know what happened to Pablo. He emails me in 2016, tells me he's doing well. He's thinking about maybe getting his tumor resected because he had an inoperable, now it all of a sudden became operable on 2 years of therapeutic ketosis. No surgery, no radiation, no chemo, just metabolic therapy. I saw him just in September when I went to England to give a lecture to the Childhood Cancer Center. He's doing fine. His wife just had a baby. You know, he's trying to raise money to get fat foods and things just to keep himself alive. And they ignore Pablo. Well, he shouldn't exist. No, Pablo should exist. And many more Pablos, and I know very many more, will be just like him if you avoid the thing that's going to put you in the grave. Right? It's biochemistry, it's neurochemistry. You got to know what you're doing. I don't know if Pablo's cured, but he's still alive and he has an enjoyable quality of life. I mean, he's in ketosis, which, you know, he's not eating pizzas and donuts and stuff like this. But he certainly measures his blood sugar and he does just what I told you. Is he one? No, we have many more like this. Now, we did a lot of work on preclinical studies. I want to share with you just briefly the studies that we're doing here. How do we get to knowing about all this? Because we do everything preclinically. I would like to, before I would be tested on anything, I would like to have someone, did that mouse, or did he do okay? No, he died quick. Well, I don't want that. You know, you take a dog and a cat. How's the cat doing? Cat's doing fine. Oh, okay, that's pretty good. So, yeah, maybe you should think about that. So, and the funny thing, you hear these people say, well, that stuff is done in the mouse. Yeah, you damn well it's done in the mouse. You don't want to be experimenting on humans before you do it. Yeah, so we do everything preclinically. We built the best animal models for these diseases. So we can predict what's going to happen when we go to the clinic, just like we predict what's going to happen when you irradiate your brain when you have a GBM. So and this is what brought us onto the glutamine issue. Because at first I was on Warburg's camp completely. I didn't know what was going on in the other half until we started to do this stuff. So on the left, these dark purple cells are ripping through the brain, invading right across from one side to the other. Then you see the one on the right. This is the hippocampus part of the brain. Calorie restriction or ketogenic diets pounded this tumor, pounded. And we stopped the invasion, but we couldn't kill all the tumor cells. And man, we did everything to hit those glucose. We just couldn't stop it. And then I said, what's the other fuel driving the beast? It's glutamine. We're not targeting glutamine with this metabolic approach that we have here. So you got to target both fuels simultaneously. So we use this drug just to test concept, proof of principle. There was a drug that's known, 6-diazo-5-oxo-L-norleucine, DON. It targets glutaminase. It's an enzyme that breaks down glutamine so the cell can use the energy. So we tested this just to test the glutamine hypothesis. And I said we put the animals into therapeutic ketosis to target the glucose. And then on the very bottom you see DON. It blocks glutaminolysis, which is the pathway by which the cell can get energy from glutamine. So you take away glucose and glutamine, and now you make the cell vulnerable because its antioxidant system is going to be corrupted. And then you go after it like that. So here's our experimental design. And this experimental design that we built in the animals, we're now using them in human clinics. So when clinicians treat patients with cancer, the first thing you should say if you have cancer, can I see your protocol for treatment? Well, you want to see I want to see what you're going to do, why you're doing what you're doing, and all these other things. So we do this, and I'll show you from the human how we set it up in human from going from the mouse to the human. So in 15 days, the animal with the high carbohydrate diet, they're dead. They're not dead, but we have to terminate them because for the Animal Rights Act and all that stuff. You don't want them to suffer. So we stopped the experiment at 15 days because the guys eating the high carbohydrate diets, their heads are swelling and you can't walk. The guy's so we put them on therapeutic ketosis and then pulse, 6, 8, 10, 12, pulse with the glutamine inhibitor, and then we compare the brains in the two groups of animals. Nice that we've engineered these cells to give off light when they're alive, and when they're dead, they give off no light. So on the top, the high-carb diet guys, you see the brilliant light, high light. That means you got a lot of living cells. In the diet group, yeah, there's living cells. We weren't able to kill those cells with the ketogenic diet, therapeutic ketosis. Stop their invasion, but we didn't kill them. Didn't kill them. Just remember that. When somebody says to you, Seyfried says you can cure cancer with ketogenic diets, here's the data that says I didn't. Okay, so we have it now at the bottom when we put the therapeutic ketosis in with the drug, no light. Okay, so what was that all about? And then we found remarkably that the delivery of the drug to the tumor is 2 to 3 times better when they're in therapeutic ketosis than when they're not in therapeutic ketosis. So one of the big problems in brain cancer is getting through the blood-brain barrier. We think we found a way to do this. So now let's look at the tissue, because ultimately you want to look at the tissue. Were you successful? So here's the high-carb diets, and you see the dark blue on the left and a little bit of light on the SDUR group. Those are the thousands and millions of tumor cells that are invading into the normal white part of the brain. And they're packed on top. They can't grow any faster. It's a mob scene. They're just piled on top of each other. The metabolic theory, the KDR by itself, you can see how whitish the white, that means they're not invading as much, and they're not as densely packed. But we're not slaughtering them. On the right, KDR plus DON, that's all dead cells. Those are cells that were slaughtered. They're all dead. And that confirms why there's no light. Light means living, okay? No light means death. And are you sure they're dead? Yeah, they're dead. And then if you look at the survival of the animals that got the combined treatment, the drug with the glutamine inhibitor, lived. And we're still working to push it out further. We want these mice to live 100 days. They're out about 50 now. We're still working on dosage, timing, and scheduling, but they're living far longer. They're much healthier. And here's a different kind of a brain cancer. Another one, and you can see the blood vessels in the left side. The ketogenic diet, therapeutic ketosis, removes the blood vessels, anti-angiogenic, and then you have mitotic catastrophe. That means the combination of the drug and the diet kills a completely different kind of brain tumor, and we think they're going to kill every kind of a tumor using this strategy. And then because they can't eat, there's nothing left for them to eat. You pulled the plug on their glutamine, you pulled the plug on their glucose, and you imploded them, and the rest of the cells are healthy because they're burning ketones. So we built this concept called Press Pulse Novel Therapeutic Strategy for Metabolic Management of Cancer. The authors on this paper are Dr. Yu, he's an oncologist from George Washington University, Joe Maroon, team surgeon, neurosurgeon, team surgeon for the Pittsburgh football Steelers, and Dom D'Agostino, who works on hyperbaric oxygen and also metabolic therapies. So we want cancer patients to come into the clinic, put them into therapeutic ketosis. You see the guy, the Vitruvian man symbol, he's red. He's got metastatic cancer. He's in bad shape. Then you bring him into therapeutic ketosis. Stress management, extremely important, just like we heard from Pam last night. Got to have stress. Stress elevates blood sugar. You reduce stress, blood sugar goes down, and these therapies work much, much better. There's a lot of ways to reduce stress. And then we pulse, bing, bing. We use various pulses. We hit with low-dose glutamine, glucose inhibitors, and then we use hyperbaric oxygen as a replacement for radiation. Hyperbaric oxygen, we think, will kill cancer cells the same way radiation does without causing harm. However, if the patient is not in therapeutic ketosis, hyperbaric oxygen will not work. Hear that? Okay, the patient has to be metabolically prepared before using hyperbaric oxygen. So it's, again, dosage, timing, and scheduling. We can kill cancer cells non-toxically if we understand the biology and the systems that are driving the beast. Now, this is an example of the tests we did on a patient in Egypt, because we can't do these studies in the United States presently, because they're against the standard of care. So here we took this gentleman. He was a 28-year-old farmer, corn farmer, and he came in, his whole left side was paralyzed. He was a metabolic mess. He had triglyceridemia, he had all kinds of other issues. So we put him on a 3-day water-only fast, and then 21 days of a very restricted ketogenic diet, and then we debulked the tumor, my colleagues, not me, await cradiotomy, so 24 days after being diagnosed. We had a blood work before we did anything to this guy, took out the tumor while he was awake, transitioned him again, postponed radiation and chemo for 3 months. Well, people yelling, no, you got to do it up front. We were able to say no. Then finally they demanded that we do radiation and chemo, demanded it. You can't get away from it. It's a violation of world law. It's written in granite. So we said, oh, okay, well, how does he do? He did pretty good. He was doing well. He did very well during the radiation and the chemo. And then he went back. He worked in the cornfield. He was back. And then we wrote this when it's 24 months. It's 2 years after diagnosis, which is pretty good. The guy died at 30 months. Came back in. He had a headache and things. So they did a debulking surgery to find out, and it was all, according to the pathologist, it was radiation necrotic damage that killed this guy. So, but we got him to live 30 months. And look, we brought his blood sugars down. He had a beautiful GKI. And if you see the red little line there on the bottom, you can see the major shift to the right, because his tumor was on this left side of his brain on this image. But at the very end, 20 months, it's straight. The guy's doing good. He's back working. And we lost him. What are you going to do? I said to them, what if we didn't irradiate this guy? How long do you think would he be like Pablo? Who knows? But I think we should try it. So people say, well, I got stage 4 cancer. They call it terminal. I'm thinking maybe these cancers should not be called terminal cancers. I think we have a blueprint and a strategy by which we can stop this growth and we can manage these people. I don't know if we're going to cure it. Who knows? You got to wait, 30? If you die at 90 years old from a heart attack and you had cancer when you were 30, you probably were cured. All you know is what is quality of life? The bottom line, how much longer can I live with a good quality of life? My hair going to fall out? Am I going to bleed from all orifices of my body? My teeth and all these problems that I have? Pablo is still going. He has a very high quality of life right now. I don't know how long he's going to live, but he certainly lived longer than Brittany, and he had a much higher quality of life. He got to see his child born, he got married. Who knows? I don't know. I can't predict the future. All I can say is we have a blueprint to do this. So when we conclude, we say cancer is a metabolic disease. It's not a genetic disease. I dedicated my book to the tens of millions of people that have suffered and died from the toxic treatments of cancer, which includes everybody who suffered like that. I think this is the greatest tragedy in the history of medicine. I think the misunderstanding of cancer is responsible for the crisis. As I said, I think we can drop the disease by 50% in 10 years if people knew how to do all this stuff. And we talked last night about all the issues that prevent us from doing this. Cancer cells are dependent on substrate phosphorylation. They ferment. If you pull away fermentable fuels, they can't survive. You don't harm the rest of the body. The pressed pulse metabolic therapy, which we tried on the Egyptian fellow, and Pablo is doing it, and others, it's non-toxic, cost-effective, and it possibly could resolve a lot of the cancers or make them better. So who do we use? We use people in the United States. We work with guys in Turkey. We have a clinic there that's testing all this out. My colleagues in Germany, Venezuela, where they do electron microscope, Hungary, Greece, France, Egypt, India. I went to China. They're very excited about applying this with their traditional Chinese medicine. We have a group that's now starting in Brazil, in Rio de Janeiro. And more physicians are getting together on the planet and comparing and contrasting their data on patients from different places. How is your patient doing? Yeah, he's doing well. Why don't you try this, try that? And these people are living longer. And if I had time, I'd show you all of these remarkable, I don't know how long these people are going to live, but they're doing better than they would have done from what we can see. So, you know, it's very hard to get money to do this kind of research. You think, wow, you should be getting a lot of money to do this. Wrong. Get a lot of money to study the disease. You don't get much if you want to try to resolve it. I get support from the Foundation of Metabolic Therapies, Joe Mercola, the George U. Foundation. Greg Glassman, owner and president of CrossFit, has become very excited about the stuff we're doing. He's been supporting us. Joe Maroon from Pittsburgh. Ellen Davis, who writes books on ways to do this, my own university. And in the past, we did have money from the NIH. So thank you very much for your attention. Thank you. Thank you. Thank you very much. I appreciate that.